Good morning. Welcome to Neovascular AMD Masterclass Part 2. I am Dr. Nipun Bagrecha, Retina Consultant at Suvi Eye Hospital. So, start from the retina. It's called as retinal angiomatosis proliferans. Start with the retina. It's an anastomist in the choroid. So, the new vessels. So, we have the predominantly what is there? The intraretinal due to the formation of new vessels from the retinochoroidal anastomosis. So, predominant what we have is the intraretinal fluid. So, intraretinal fluid we have. So, that's why it has the poorer, worse prognosis as compared to the type 1 and type 2 CNVM. And sometimes we can have a mixed kind picture of CNVM also, in which type 1 sub-RP fluid and subretinal fluid are there. So basically mixed kind of picture of CNVM with type 1 and type 2, and even the intraretinal fluid can be there. What is pigment epithelial detachment, and like what are the types of pigment epithelial, Dr. Shreya?
So pigment detachment is when the retinal pigment epithelium is getting detached from the underlying Bruch's membrane, and the types can be it can be a single, depending upon the size also is there. It can be I also forgot now, sir.
Drusenoid, hemorrhagic, serous, and one fibrovascular.
Yes. Right.
Yes.
So serous, fibrovascular, hemorrhagic, and drusenoid PD can be there. So out of which one type of PD is seen in type 1 CNVM or occult CNVM mostly? No. Fibrovascular PD. Late leakage of undetermined fibrovascular PD is seen in your type 1 CNVMs. So, if why a PED is important, so as we discussed like twice before. So, if we Dr. Anuj, so like if we have a very large PED and a notched PED, then what are we suspecting at?
Polypoidal.
Yes.
Choroidal vasculopathy.
So why is it important to differentiate polypoidal choroidal vasculopathy? Is that okay? There is a fluid there. The patient comes to me. So as retina consultant, there is a fluid there. The treatment is anti-VEGF only. So why is it important to differentiate between PCV if you don't have a FFI ICG? Even if you have a FFI ICG, why is it important to differentiate from the other types of CNV or a neovascular AMD?
To know the prognosis.
And
We choose Eylea. More.
So we choose the choice of injection depends on the diagnosis. That's why it is important to differentiate. So our first line of drug changes with the diagnosis of polypoidal choroidal vasculopathy. So Dr. Sudhanshu, so what are we discussed the OCT, ICG is not available everywhere. Many less places have ICG. So ICG was the gold standard for diagnosing of choroidal pathologies, polypoidal choroidal vasculopathy. So what are the OCT based diagnostic criteria for PCV? The 4 diagnostic criteria that we discussed.
There will be club shape and neovascularization will be seen sub RP level.
Okay.
And thumb like
PD, right?
Sir, multilobular PED, notched PED,
Right.
and thumb-shaped PED.
Thumb-shaped PED, complex and multilobular PED. There will be a big PED with a notch, which will be like an M-shaped PED. Okay. And one is the what is the very important described as SIRE, shallow irregular RP elevation. Also double A and the presence of double layered sign. So what happens in double layered sign? Anyone?
RP and Bruch's membrane.
Loudly.
RP and Bruch's membrane separation.
Yeah, very nice. So RP and Bruch's membrane separates with the presence of hyperreflective material in between. And the last thing is a sub-RP ring-like lesion. So I am emphasizing on this because if we see this kind of picture, then practically our diagnosis will change to the polypoidal choroidal vasculopathy. And polypoidal choroidal vasculopathy is a spectrum of pachychoroid, whereas in AMD the choroid is thinner, age-related thinner. In pachychoroid this thing is choroid is thicker. Although 20% of the patients, and as per the study, even with the leptochoroid, have polypoidal choroidal vasculopathy. So it is a predominantly a spectrum of pachychoroid. So this is regarding the pachychoroid. This is regarding the polypoidal choroidal vasculopathy, and these are the types of PD as mentioned by Dr. Himanshi ma'am: brucinoid, fibrovascular, hemorrhagic, and serous. So we have patients with sudden diminution of vision, complaining of sudden diminution of vision in one eye, and then we see they are suppose they are non-hypertensive, non-diabetic, and we see there is a subretinal bleed, and if there is a at the macula, submacular hemorrhage, basically it submacular hemorrhage more than like around 3 to 4 disc diameter in size. So what will be your first, how will you manage that case? Practical situation. Suppose a 65-year-old male came with a sudden diminution of vision, and on both eye pseudophakia, IOL is clear, and this thing, on examination the left eye has submacular hemorrhage, vision is finger counting 0.5 meter. So what will you advise first?
OCT.
Okay, nice. OCT, then OCT we see there is a there is a sub RPE, there is this kind of PAD, hemorrhagic PAD is there, but it is very elevated, sort of this, but it is a big PAD. Okay, so what will be their first line of investigation?
OCT.
First line of treatment, management?
Eylea injection, anti-VEGF.
So she is going with aflibercept injection. So first 3 months, 3 loading doses of aflibercept injection. Even the size of the submacular hemorrhage, remember, it matters. Whether if it is more than 4 disc diameter, also advise for counsel for regarding the retinal surgery as well. Okay, so even because the submacular hemorrhage more than 4 disc diameter, sometimes they do not resolve with the intraretinal anti-VEGF injection, but the first line should be your intraretinal anti-VEGF injection. Some people are giving intraretinal anti-VEGF injection plus this thing, gas injection also combined with that for the pneumatic displacement of the sub-RPE blood. Okay, the pneumatic displacement they are giving also.
Sir, gas injection when it is 3 disc or 4 disc diameter?
When it is more than around 4 disc diameter. So, and or when it is an old clotted blood, suppose the patient comes late, so an old clotted blood, so we want to, already the prognosis is poor, so you want to displace the blood. But what happens with the gas injection? When we inject the gas, the IOP increases, because around total 0.1 ml of gas and 0.1 ml, around 0.2 ml total we have to inject, and the gas is there is to lie down prone position also, and the IOP also increases. We give IOP lowering, we give IOP lowering Diamox and IOP lowering drops also. But this thing is that it displaces. If it displaces then it is good. Otherwise, like the surgery, we are looking at the last resort because of the financial consideration also, because they use subretinal tissue plasminogen activator also. So that drug also comes costly. So it adds to the surgery cost also. So as much as conservative management we try, it is better. Now these are so what are the other biomarkers we discussed regarding SHRM? We discussed regarding outer retinal tubulation, intraretinal cysts, intraretinal fluid, intraretinal cyst, and what are the other biomarkers left? Two retinal biomarkers are left. Then we go on to the choroidal biomarkers. So what are the 2 retinal biomarkers left? Anyone? Which one biomarker which is common to AMD, DME, and vein occlusion?
Serora.
No, Serora is of the AMD. Yes,
Dots.
very good. Hyperreflective foci. So suppose like I'm shifting a little bit out of hyperreflective foci. So what are hyperreflective foci, and how do we differentiate? With the, like, suppose sometimes CNVM also has hard exudates. Even in DME or vein occlusion, if we particularly in DME, if we have hard exudates, So how do we differentiate between them? Hyperreflective foci and hard exudates.
Hard exudates have back shadowing.
Backshadowing, because they are, why they have backshadowing and why hyperreflective foci they don't have backshadowing? Simple, because of the size. Because they have the higher hard exudates are larger in size, more than 300 micron in size, and it is more than 30 micron in size, and hyperreflective foci are smaller. Hyperreflective foci are supposed to be the precursor of hard exudates. They are this thing of inflammation. They are the precursor. They are the biomarkers for the inflammation. And one more biomarker is coming to your integrity of which layer? Our photoreceptor layer integrity. If integrity is lost, it is disrupted, then the conduction will be disrupted. So like the prognosis will be poor. So what are there in the photoreceptor layer? There are two zones. One is the ellipsoid zone and one is the interdigitation, EZ and the IZ. So both the bands, if the integrity is lost, then your prognosis is poor. Okay. Now coming to this thing, choroidal biomarker, hyperreflective dots we discussed about.
Hyperreflective dots will mean
Hyperreflective dots will mean it's an inflammatory biomarker. It has a poor prognosis, and if it is sometimes associated with STEM, some consultants have even tried addition of small amount of intravitreal triamcinolone also to for that vascularized STEM. Otherwise, there is no role of intravitreal triamcinolone for CNVs. And why outer retinal tubulation formed anyone? Outer retinal tubulation we discuss are degenerative cysts. So what happens due to the chronic stress on these photoreceptors and Muller cells, they degenerate and they roll on themselves. So that's why they formed like this thing, ovoid shaped outer retinal tubulations. So these are due to the photoreceptor and Muller cell degenerations. Suppose say there is a tall tense PED, and if we inject any anti-VEGF due to the pressure, due to the inside the tense PED pressure, suppose if we inject anti-VEGF, there is an RP tear. So what will happen? The vision will further loss. So it will deteriorate. But we should continue with the anti-VEGF injections. Do not stop the anti-VEGF injections. It's a good point. We should continue with the anti-VEGF injections. So after the anti-VEGF injection treatment, if you do an OCT, then you trace the RP. If there is an RP tear, so you can explain the prognosis to the patient, but you continue with the anti-VEGF injections. Okay, don't stop the treatment. Vitromacular alterations. Okay. Subretinal hyper. Coming to the choroidal biomarkers, so they have these clefts and prechoroidal clefts and choroidal K1s. Prechoroidal clefts, I was studying. Anyone? What are prechoroidal clefts? No. Choroidal clefts are these there's spaces with a hyporeflective space between the RP and the Brooks membrane. The sub-RP, these are the hyporeflective space, and which is more common in the type 1 and type 3 CNVM, less common in type 2 CNVM. It indicates a poor prognosis only. And the newer drug, the faricimab, which inhibits both faricimab inhibits which all two receptors? Anyone? It's Ang2, angiopoietin 2. Angiopoietin 2 and VEGF receptor. Very good. So they have in various studies they have shown to ameliorate this prechoroidal cleft, but it is said to be a poor prognostic factor. It is because of the outward bowing of the Brooks membrane. The prechoroidal clefts are formed. Even the degenerative cysts in the choroidals, some small choroidal K1s are also formed. These choroidal K1s are also formed. It also indicates these poor prognosis in choroidal K1s.